Welcome to this explainer. I am absolutely thrilled you're here with us today. We're going to take a super fascinating set of clinical notes and decode them into a crystal clear medical journey. We're looking at peripheral vascular disease, or as we're calling it, the ticking clock of limb ischemia. It's a pretty complex topic, but with the visual breakdown we've got ready, we're going to master exactly how medical pros identify, classify, and treat blockages in the blood vessels of our limbs. So get comfortable, lock in, and let's unlock this clinical puzzle together. All right, here's our quick roadmap for today. 1. The blood flow crisis. 2. Acute limb ischemia. 3. Chronic limb ischemia. 4. Diagnosing the blockage. And finally, 5. Treating and saving limbs.
Okay, let's jump right into section 1, the blood flow crisis.
Imagine this scenario for a second. You're in a busy emergency room and a patient rushes in. Their leg has suddenly, literally without any warning, lost its entire blood supply. The oxygen is cut off and the tissues are absolutely starving. Now, this isn't some gradual issue we're talking about. This is a sudden, high-stakes vascular emergency. The clock is immediately ticking on whether or not that leg can actually be saved. So how do doctors quickly identify this exact crisis? Well, that brings us to their immediate clinical checklist, commonly known as the 6 Ps. Let's break them down. First, paresthesia, which is basically an abnormal sensation, kind of like severe tingling. Next is pulselessness, meaning exactly what it sounds like, no heartbeat can be felt in that limb. Then paralysis, the total inability to move it. Pain, obviously. Poikilothermia, which is just the clinical term for coldness in the limb. And finally, pallor, meaning the skin has turned completely pale. Listen, when these 6 Ps show up together, the body is practically screaming that a catastrophic blockage has just happened. Now, before we go any further, let's make sure we really anchor our understanding here. Ischemia. What does it mean? It's defined as severely restricted blood flow to a part of the body, which immediately threatens tissue viability. In simple terms, the tissue is literally on the brink of dying because it just can't get the oxygen-rich blood it desperately needs to survive. Okay, let's dive into this. Peripheral vascular disease essentially splits down into 2 completely distinct timelines. On one side of the coin, we have acute. This is that sudden emergency we were just talking about. It's often caused by an embolic blockage, basically a renegade clot that travels and just suddenly wedges itself in a vessel. On the flip side, we have chronic. This is a much more gradual buildup over time, and it's characterized by something called claudication, which we'll define in just a bit. But think of it as a slow, creeping progression rather than a sudden lightning strike. Moving right along to section 2. Acute limb ischemia. Take a look at this escalating scale. It's called the acute Rutherford classification, and you can really see how the tension builds here. In class 1, the limb is still viable, right? There's no pain, and a medical Doppler device can still actually hear the blood flowing. But as we move into class 2A, it gets marginally threatened, and numbness starts to set in. Drop down another level to class 2B, and bam, it is immediately threatened. We're seeing persistent pain and actual sensory loss. That Doppler signal, it might be totally gone. The window to save this limb is closing super rapidly. And then we hit the bottom of the table, class 3, irreversible with profound anesthesia. By the time a patient reaches class 3 on this acute scale, the clinical reality is incredibly grim. That tissue viability we defined a minute ago, it's completely lost. At this stage, the medical notes are very clear. The expected outcome is delayed amputation. The ticking clock has unfortunately run out. So what's the game plan? How do doctors stop a patient from ever reaching that dreaded class 3? It requires an incredibly rapid medical response. It kicks off with a clinical evaluation and a Doppler exam. From there, it's on to immediate heparinization, which means using a drug called heparin to heavily thin the blood and stop any existing clots from getting worse. Next up, they use contrast angiography, either right before or actually during surgery, to map out exactly where that blockage is hiding. And finally, the physical intervention, an embolectomy to physically remove the clot or some other emergency surgery. It's literally a race against time. All right, on to section 3, chronic limb ischemia. Now, just like the acute pathway, the chronic pathway has its own Rutherford classification scale. But this one builds way more slowly. It starts at class 0, where the patient is actually completely asymptomatic. They feel fine. Then check out classes 1 through 3. These are categorized by that word we mentioned earlier, claudication, ranging from mild all the way to severe. And claudication just simply means getting pain or cramping in the legs while you're walking, which then magically goes away when you rest. But as the disease slowly progresses down to class 4, the patient starts experiencing pain even when they're just resting. Class 5 brings minor tissue loss, and finally, class 6, that's when we reach severe tissue loss or full-blown gangrene. You know, what's so incredibly striking about chronic limb ischemia is this insidious, almost sneaky progression. Unlike the acute crisis where the leg is immediately threatened in a matter of hours, chronic ischemia gives you a much, much longer warning period. It slowly escalates from just a slight limp or a little cramp during your evening walk, creeping all the way up to pain while resting, and finally, if it's totally ignored, that catastrophic stage of severe tissue loss and gangrene. Let's move into Section 4, Diagnosing the Blockage. And this brilliantly illustrates the detective work doctors have to do. It's a highly logical, step-by-step escalation of diagnostic tools. Step 1 is always the foundation, the history and clinical exam. Step 2 brings in the hand Doppler, so they can actually listen to the blood moving. Step 3 is the ABPI, which is a test comparing blood pressure in your arm to the pressure down in your ankle. If they still need more detail, Step 4 is a duplex scan. And finally, if surgery is serious and on the table, they escalate to Step 5, angiography. Every single step paints a deeper, clearer picture of the patient's vascular highway. So let's briefly unpack what these doctors are actually hunting for with these tools. With that hand Doppler, they're listening for very specific signals, triphasic, biphasic, or monophasic flow. Basically, this tells them just how healthy the pulse really is. The duplex scan, particularly something called a B scan, hands them crucial data on the flow, the turbulence of the blood, and the actual physical anatomy of the vessel itself. But if a patient has critical limb ischemia and absolutely needs an operation, the angiography is the ultimate requirement. It gives the surgeon the definitive, highly detailed map they need before they make a single cut. And that brings us to our final stop, Section 5, Treating and Saving Limbs. Okay, so how do we fix this? Treatment always starts with foundational lifestyle and pharmacological changes. The very first non-negotiable mandate is lifestyle modification. We're talking about stopping smoking entirely, walking for about 40 to 60 minutes 3 times a week, improving your diet, and really prioritizing careful foot care. On the pharma side of things, doctors are going to prescribe analgesia to manage the pain, antiplatelets to prevent further clotting, and some specific medications like cilostazol and statins. Honestly, getting a handle on these comorbidities is the absolute first line of defense to stop this disease from marching further down that chronic scale we looked at earlier.
But what happens if all that isn't quite enough? Well, that's when surgical interventions come into play. And again, we have escalating options here. There's PTA, which is basically an angioplasty to physically widen out the vessel. If that won't do the trick, a bypass graft can actually route the blood entirely around the blockage. We've also got direct arterial endarterectomy, which is a procedure to surgically clean out the inside of the artery, and lumbar sympathectomy to help improve overall blood flow. But resting at the very bottom of this list is the tragic final outcome if blood flow just cannot be restored: amputation. It is the absolute heartbreaking last resort when the tissue simply cannot be saved.
Wow, we've covered a tremendous amount of ground today, haven't we? We've navigated everything from the sudden, scary emergency of the 6 Ps all the way to complex bypass grafts. But as we close out this explainer, I really want to leave you with the profound thought that comes right from the clinical source material. Amidst all of those advanced duplex scans, the heavy heparinization, and the high-tech emergency surgeries, the very first, absolutely most critical preventative prescription for chronic limb ischemia is astonishingly simple. Ready for it? Stop smoking. It really makes you stop and reflect on the immense power of our daily lifestyle choices in preventing irreversible vascular damage. The power to stop the ticking clock of limb ischemia might just begin with the choices we make today, which kind of makes you wonder, doesn't it? What other hidden ticking clocks might be resting inside our daily habits, just waiting for us to pay attention? Thank you so much for learning with me today, and I will see you in the next explainer.